very warm welcome from the FLCCC team. This is Dr. Mobeen Sayed. Today we are going to look at a study that is published in the Journal of Pediatrics. And the study is conducted in Seattle's Children's Hospital. Study is about the heart condition after 3 to 8 months of developing myocarditis after the second dose of Pfizer vaccine in children. That is a study very interesting. The summary is that as majority of the cardiac abnormalities or indicators for the abnormalities had actually trended downwards or disappeared, there were some abnormalities that kind of allude to or indicate persistent fibrosis or non-resolved fibrosis in the heart to be present even after 3 to 8 months. So let's look at this study. It is, of course, concerning, but there is a good news as well. There are two things to keep in mind. Number one, you would see that a lot of patients, these children, became better. And number two, you would see that those children that were treated with IVIG plus steroid, they had a tendency to have a better outcome compared to those children that were only given NSAIDs during their hospital stay. So let's look at this study. So here's a study, the Journal of Pediatrics, persistent cardiac MRI findings in a cohort of adolescents with post-COVID mRNA vaccine myopericarditis. And I want to start with the important part of their discussion, and then we'll go over the details. So here, this is their discussion. And they say, although symptoms were transient and most patients appeared to respond to treatment solely with NSAIDs, we demonstrated persistence of abnormal findings on CMR, cardiovascular or cardiac magnetic resonance, that is an imaging technique, at follow-up in most patients, at follow-up 3 to 8 months in most patients, albeit with improvements in extent of LGE. And LGE is late gadolinium enhancement, and this is an indicator for fibrosis in the heart. So if I can quickly show you some of the pictures and then continue. So these white areas are indicative of fibrosis or toxicity in the heart muscle cells. This is usually extracellular problems, and these are indicated here. And if you see here, this was at the acute disease, and here we can still see some remnants of this LGE, and that is what is the potential concern. So if you see here as well, and versus here, this third diagram, this is a circumferential area of the left ventricle, and this is the enhancement, which is resolved here. So some areas were resolved and some were not resolved. So now let's look at my presentation, and we'll go from there. So as we just saw, that the discussion is that there are abnormalities in imaging that persisted. That means there are issues in the heart that persisted. So what is this case series? So they didn't call it a study because it is small. It is a case series. It is done in adolescents 16 to 35. So there were 35 patients. Out of them, 16 were included, and the remaining were excluded because they didn't come up for the follow-up, or they did not get their CMR or the imaging done at the right time, etc. Median age of these children was 15 years. Imagine cardiac problems at the age of 15. Range, these children who developed the inflammation of the heart were from 12 to 17 years of age. 94% were males. So out of these 16, 15 were males. And then 88% were white and non-Hispanics. One was Asian, one was Native American. This was the breakdown. What researchers did was they looked at their cardiac status through imaging 3 to 8 months after their acute cardiac inflammation. So acute cardiac inflammation occurred within the 7 days of the second dose of the Pfizer vaccine. Then these children were followed up from 3 to 8 months. And you could say, why 3 to 8 months? And the researchers say that it was about the safety, maybe COVID related delays. And secondly, it was also the availability of the testing machines and procedures and the staff maybe. So 3 to 8 months after the acute myopericarditis. What was the summary? What did they see? So there is a table that has a lot more data. I have picked up those data points that are interesting for us to understand. So the first thing they saw, echocardiographic left ventricular ejection fraction. So ejection fraction is that, let's say, the amount of blood that is present in the left ventricle before it beats, before it squeezes to try to push that blood out. And then when the left ventricle actually squeezes, which is called systole, and it pushes the blood out, the question is how much blood out of the blood that was present in the ventricle is pushed out. That percentage, that fraction is called left ventricular ejection fraction. Normally it is more than 55%. So whatever is the volume of blood present in the heart, about more than 55% is ejected in a beat. So if you see here, when the patients were acutely had inflamed heart, the ejection fraction was 59.4 plus minus 6.4. So not bad, more than normal. And as the follow-up occurred, the ejection fraction was 62.6% plus minus 2.8. So all good. So that means function of the heart overall stayed competent. But this does not mean that the heart itself was all good. Many heart patients actually continue to have good function while the heart deteriorates, and then at some point the function drops. Again, these are children. They would not have such outcomes so soon, but I cannot claim that. This is what these researchers are trying to figure out. And this is the data they found. The researchers promised that they would do another follow-up at a year and then come back with that data too. So it will be very interesting. So the long-term effect so far we can see is within 3 to 8 months. Then is the CMR, cardiac magnetic resonance of the left ventricle ejection fraction percentage. So measuring the left ventricular ejection fraction with imaging, CMR imaging. So when the patients, these children, had the acute inflammation, the ejection fraction was 54.5 plus minus 5.5, and then it improved to 57.7 plus minus 2.7. So again, fine, not bad, and the p-values are significant. Then the CMR LGE. So on this cardiac magnetic resonance, late gadolinium enhancement. So that is a dye that is given, and this dye's function is that it doesn't tell you what is happening inside the cell, but it tells you what is happening outside the cell. And that is very important, because if there is inflammation going on, if the cells are breaking down, there is debris present, there is congestion present, there is fibrosis present, LGE kind of tells us if edema and fibrosis is present. So if I go back for a second to that diagram that we saw, this diagram, this presence of this area, this whitish area, LGE, indicates that in this heart over here, there was edema and fibrosis. Maybe edema at the acute disease and then later on fibrosis. And that is what they're trying to figure out. But this is what LGE tells us. So 15 children had the LGE done. At the acute disease, the LGE was 13.5 plus minus 8.3. So again, this should not be high. We should not see edema and fibrosis anywhere in the heart, but there it was. And then at the follow-up, 3 to 8 months later, there still was LGE, although improved from 13.5 down to 7.7. So that was good, but it was still present. So 3 to 8 months later, we could still see, or the researchers could still see, abnormalities in imaging of these hearts. And it is actually very interesting that if you go to their messaging, they say here, in a cohort of adolescents with COVID-19 mRNA vaccine related myopericarditis, heart inflammation and its layers, a large portion of the children have persistent LGE abnormalities, raising concerns for potential longer term effects. And this is why I wanted to record this video to go in the long COVID. This is, of course, not long COVID. This is a post-vaccine situation, but this is also long-term situation, and we as doctors must be aware of this situation. So we should not simply say that somebody, a child, had cardiac inflammation, or even an adult had cardiac inflammation, and a week or 2 weeks later it's all good. No, you can see over here, it may not be all good. And then finally, another abnormal imaging that persisted, or imaging marker that persisted, CMR global longitudinal strain. And I'll explain what that is. This number actually did not improve at all. It was minus 16.0 plus minus 1.7, and it stayed minus 16.4, almost the same, plus minus 2.1. This is why the change was not significant, which is actually a bad thing. We wanted this to change significantly and to improve significantly, and it did not. A normal value is minus 18 or lesser. So what is this? Let me just very quickly, actually I have a picture of this. So here, this, if you look at the picture A here, and credit goes to this, the link you can see up here. So on the A picture, it says ED, end diastole. This is the maximum relaxation of the left ventricle before it pumps. So that is a time when it is filling with the blood. And this is where the length and the circumference of the heart is most relaxed. So length will be longer, circumference will be bigger, so the cavity is open to receive blood. Then the heart would pump or squeeze or go in a systole. In the systole, the length will reduce, as you can see in the B diagram, and also the circumference would reduce, as you can see in the B diagram's end. So sorry, the first one is in the diagram, second diagram in A, and the second one is second diagram in B. And the longitudinal strain is calculated by seeing that what percentage of length change occurred. And it's a very simple formula. You take the end systolic length, or the length at the maximum squeezing of the heart or pumping of the heart, and you subtract that from end diastolic length, that is the initial length at the end of the diastole, or when the heart was fully relaxed. You subtract them, and then you take the fraction from the fully relaxed heart. So if you see here, left length end systolic minus length end diastolic divided by length end diastolic multiplied with 100. So that is a fraction, right? Percentage calculation. And normally it is minus 18.5 or lesser. And here it was, number one, at the time of acute disease, it was minus 16. It was reduced. The heart was not reducing in length correctly because it was damaged. This is just like if your hand has an injury and I ask you to make a fist and squeeze hard, you might refuse to do that because your hand might have pain in it. So same way, heart did not fully contract in length, and after 3 to 8 months that situation did not change. That is a concern. So if you see here in their findings, they then say here Notably, in our cohort, though there was significant reduction in LGE, that is the uptake of the late gadolinium enhancement or indicator for the fibrosis and edema, so that was reduced. Abnormal strain, that is this LGS, global longitudinal strain, GLS, abnormal strain persisted for the majority of the patients at follow-up. So back here. Now some details. So let me back up for a second. What does this mean? I want to add one more statement here, which I would actually discuss later on as well. The patients then stayed in the hospital anywhere from 1 day to 2 or 3 days. They were given either NSAIDs, non-steroidal anti-inflammatory drugs, and that's about it, or they were given IVIG plus minus steroids. That was the protocol in the hospital. So this is important for the doctors here to see that this is the protocol, and the outcome was that those patients that had received IVIG plus steroid or IVIG alone, they had a better outcome. So let me show you that. The patients who received IVIG alone and one patient who received IVIG plus corticosteroid, and reminder, there were 2 patients who were given IVIG and corticosteroid. So out of these 2, and one patient who got IVIG, had resolution of LGE. So the late gadolinium enhancement was resolved. That means there was no fibrosis, there was no edema at the follow-up. And the other had persistence of LGE. So all other who were given anti-inflammatories and SAIDs actually, they had persistence of LGE. That means as a healthcare provider, this is an important clue for management approach. Okay, so back here, now we're going to go in details. The details are, this study was done for those male patients, for those patients who had received Pfizer-BionTech and had developed Myopericarditis within the 7 week. There were 35 total patients, 16 were included. The patients during the acute attack, during the first attack, they all had chest pain. 37.5% had fever. Another 37.5% or 37.5% had shortness of breath. Median time to present, meaning you got the second dose, the child, and then how long before they come to the hospital saying I have chest pain? 3 days. Range was 2 to 4. So within 2 to 4 days, the child developed heart pain. When they came to the hospital, the troponin levels were increased in all of them. What are the troponin levels? Heart cells, imagine they are like closed cylinders. Inside these cylinders is contractile machinery that makes the heart contract and relax. In that machinery, there is a protein called troponin. If the heart muscle cell breaks down because of damage to it, because of abuse to it, inflammation, injury, that troponin will leak out from the broken cell. Imagine you have a water bottle which gets a hole in it. Now the water is going to come out. Same way, troponin would come out and go in the blood, and we can then measure it. And all of these patients had troponin levels in the blood. And what were the levels? Normal is 0.05 or lesser nanogram per milliliter. And they had median 9.5 nanogram per milliliter. Range was anywhere from 0.65 to 18.5 nanogram per milliliter. And the more the troponin, the more damage it indicates. Then 12 out of 16 patients also had C-reactive protein that was high. And we all know now C-reactive protein is a protein that is released by liver during the acute inflammatory processes. Normal range for C-reactive protein is 0.08 milligram per deciliter. And for these children with the heart inflammation, it was 3.45 milligram per deciliter, which was median. Otherwise, 0 to 6.5 milligram per deciliter was the range. 10 of the patients had abnormal EKG. And in the abnormal EKG, if you are a healthcare provider, you would know ST segment elevation was observed. So it was a STEMI. I shouldn't say STEMI because it was not an infarction, but it was ST segment elevation with inflammation. 2 patients actually had left ventricular ejection fraction reduced, and it had reduced down to 45% and 53%. Remember that normal is 55% and above. So their heart actually reduced its function because of the inflammation in it. None of these patients, 16, had pericardial effusion. Pericardial effusion is the fluids and congestion and material inflammatory substances oozing out in the sac around the heart. Now, cardiac magnetic resonance, CMR, was abnormal for all of them. So there was edema, there was length change, there was fibrosis. So LGE was abnormal, which is edema fibrosis, and CMR was abnormal, which is the functioning of the heart itself. And the kind of inflammation they saw were transmural plus subepicardial. And what does that mean? Transmural, if you see here, when the whole thickness of the heart wall, not all the wall, a small part of the wall, but the whole thickness of the wall is involved, then it is called a transmural inflammation or infarction or whatever the type of injury it is. So there were patients with transmural, that means the whole thickness of the wall was involved. That actually is not a very good thing because that area of the whole wall thickness that became affected, that could cause fibrillations, that could create a scar over there. It could become a weak area of the heart in long term. There could become fibrosis there. So there is a problem there. In some patients, they actually saw subepicardial edema. What does that mean? So if we look at these layers of the heart from inside outwards, the most inner layer of the heart that is in contact with blood is called endocardium. Then outside of that layer is the muscle called myocardium. Then outside of the muscle is a layer called epicardium. Subepicardial edema is between the muscle and the epicardium. There is edema and inflammation there. And just for completion's sake, then there is a tiny bit of a cavity that is filled with some fluids to allow the heart to slip and do the movement without getting rubbing against the outer membrane. And the outer membrane is the parietal pericardium and fibrous pericardium. So this is the one that makes a sac around the heart. So there was edema here and there. In some cases, the whole depth of the wall was involved. Now, the management for the patients, all of them received NSAIDs, non-steroidal anti-inflammatory drugs, and 10 milligram per kilogram ibuprofen every 8 hours. 4 patients did not receive this scheduled protocol. They were on as needed basis. 2 patients received IVIG plus corticosteroids because they had left ventricular dysfunction. And as I said before, out of these 2, 1 patient showed no abnormalities in the follow-up imaging. It is interesting that that patient was actually having a left ventricular dysfunction, was more severe. So severe that IVIG plus corticosteroids were given, but the benefit to this 1 patient was, out of these 2, that there was less damage onwards. So it seems like steroids and IVIG are important. One patient had received IVIG, intravenous immunoglobulins, only, and as I said before, this patient also did not have any signs of abnormalities later on. The patients were discharged when their chest pain had resolved and when their troponin levels were downtrending. No patients had to go on heart failure medicine. Follow-up was done 3 to 8 months, as I mentioned before. Another follow-up will be done at a year, and we'll see the results as well. So authors say that one of the observation by some other studies has been that the reason for myocarditis is possibly because of the short gap between the two vaccine doses. And they say that CDC has increased the gap between the two doses to 8 weeks, considering these studies, and maybe these would help. I wanted to read a couple of more comments. In one of the comments in the paper, they said, notably in our cohort, though there was significant reduction in LGE, abnormal strain, that is GLS, global longitudinal strain, persisted for the majority of the patients at follow-up. Their heart did not increase and decrease in full length as it was or as it should. Then they say further follow-up assessment and larger multi-center studies are needed to determine the ultimate clinical significance of persistent CMR abnormalities in patients with post-COVID vaccine myopericarditis. That is the study. We would, of course, wait for the follow-up after a year, but this study to me is concerning. There may be an extrapolation of this for the long COVID as well, to see maybe after COVID, when patients have cardiac abnormalities, do they also have these persistent abnormalities, and did various drug protocols had varied outcomes? So this is the discussion. Thank you very much for being here, and talk to you later.